So we move on to the next session. The presenter is Dr. Smilu Mohanlal, Hepatomegaly and Seizures, what is the link? Moderator, Dr. Seema Alam. Panelists, Dr. Priya Kishnani, Dr. Mamta Muranjan, and Dr. Manoj Ghoda, please.
Good morning, everyone who are present over here. I am Dr. Smilu Mohanlal from Nair Hospital, presenting you the case of hepatomegaly and seizures. What is the link? Our patient was a 5-year-old boy born of 3rd-degree consanguineous marriage, second by birth order, Hindu by religion, Gujarati by caste. He presented to us when he was 1.5 years of age with abdominal distension noticed by the parents.
Go slow, just go back to they have not seen it. Yeah.
He presented to us at the age of 1.5 years with the history of abdominal distension which were noticed by the parents. The parents noticed his abdominal distension, which was insidious in onset, gradually progressive in nature since the time of birth. There was no history of jaundice in this child, no history of fever or constipation, no history of any drug intake, no history of any muscle weakness in this child. The parents, however, complained of increased appetite in the child in the form of early morning 3 a.m. awakening for a milk feed, followed by every 2-hourly demand feed by the child. Failure to provide the same made the child irritable and restless. The child was born full-term normal delivery, no history of any NICU stay, no family history of a liver disease or a bleeding disorder. The child was gaining The child was gaining weight adequately for age, the developmental milestones being appropriate for age.
Okay, so with this, the two problems that the child was facing and the parents noticed was, 1, abdominal distension, 2, that the child was having to, would get up early in the morning, very irritable, restless, wanting feeds, wanting to be fed again and again. Can somebody among the PGs and the general pediatricians tell me as to what would you interpret here from this simple history? Okay, so there is a possibility of maybe there is an abdominal distension, whatever the reason, we'll look at it, but there is definitely an element of an early morning, maybe hypoglycemia is one possibility that we'll keep with this irritability. Would you agree with it, the panelist, Dr. Manoj?
Yeah, I think hypoglycemia, everybody would expect hypoglycemia.
Is there anything else that you would feel?
Given the fact that there was history of progressive abdominal distension, one would think of a hepatomegaly with symptoms of hypoglycemia.
Yeah. Okay, so we'll go ahead. Yeah.
On examination, his vitals were stable, anthropometry were at the 50th centile, there was no pallor, icterus, lymphadenopathy or clubbing in this child, there were no obvious dysmorphic features or faces, there were no features of rickets on examination. System examination, however, showed a soft abdomen with a non-tender liver of 6 cm below the costal margin with a span of 11 cm, the left lobe of the liver being more palpable than the right lobe and spleen not being palpable, with other systems being normal.
So could we just ask one question? Why were you thinking about rickets here? What was you put that right in?
Since the child had come to us with abdominal distension and hypoglycemia, so we thought that the child might have any metabolic cause underlying, so that made us think about the people here.
Can you ask the people this question, the students?
I was just asking why she was looking for rickets
in this particular child.
Yeah.
Like Dr. Mamta said, that possibly there could be an organomegaly, maybe a hepatomegaly, and possibility a history of hypoglycemia there. So Dr. Priya's question is, why would you look for rickets? Huh? Come loudly. There's no. RTA can cause rickets. Is that what? Hepatomegaly with hypoglycemia. Okay, so you think of tyrosinemia as one possibility. Anything else that's coming to your mind? There's no jaundice there. Anything else without jaundice, hepatomegaly? Only hepatomegaly. But yes, go ahead. Use the mic, yeah, we can see you. We want to see the people who's. Okay, so the next possibility you want to keep is Gaucher's disease. do you see hypoglycemia, or if we don't have a documented one, we just have a history? That kind of a history is there? Okay. So,
So, I'd just like to make a comment. If you're looking at a liver disease with rickets, you're thinking whether this is a liver disease with jaundice and rickets or a liver disease without jaundice and rickets. So immediately you'll be able to have a set of differential diagnosis for both. So can somebody volunteer? What would be these two entities? Liver disease, jaundice and rickets, and liver disease, hepatomegaly, without jaundice, without liver cell failure, and rickets.
Yeah, come up, one of you. I think some of them were even talking. Hepatomegaly with jaundice, with rickets, or hepatomegaly with rickets, without their jaundice being there. So for the first entity, so for the second entity, people have spoken, but what about the first entity with jaundice?
What type of vitamin is it? What type of where is it absorbed?
Yeah. Yeah. So, like yesterday we had this case where there was no jaundice in that, and that's what's puzzling us all the time. Dr. Girish was saying that why is there no jaundice, there's so much of florid rickets there. So that is one. What possibilities would you keep? Can we ask Dr. Mamta to?
I think when we are having a child with jaundice and liver disease, one thing is whether the rickets is because of malabsorption of vitamin D. The other situation will be a child with jaundice and signs of liver cell failure like tyrosinemia, hereditary fructose intolerance, and those group of disorders. In an older child, even Wilson disease. So that would be the first group. And the second group, we are looking at unusual presentations of disorders such as glycogen storage diseases, which are known to have renal tubular problems. And these would be the ones without any jaundice, or maybe in the early stage, no signs of liver cell failure.
What we basically wanted an answer is that, one, there could be malabsorption and nutritional ricket-like picture with liver disease. Two, it could be a cholestatic liver disease, and there is again, rickets associated with it. Three, there could be, because of liver disease itself, because of this, the synthesis of 25-alpha hydroxylase, the liver disease itself can give rise to, rickets. Then, of course, finally, some of the diseases which cause liver disease can also have renal tubular acidosis, like she put it. And see, so these are the 4 ways in which rickets can come along with the liver disease.
So just as a point here, you were talking about the GSTs. So you could have renal tubular acidosis and glycogen storage disease type 1, but very rarely will you have features of rickets. It's more in GST type 11, Fanconi-Bickel, where you would actually see the signs of rickets, and that comes on pretty early. It's a very aggressive disease.
However, there were 2 episodes of generalized tonic-clonic seizures at the age of 1.5 years, recovered by IV infusion at local hospital with immediate regain of sensorium. At that time, the child didn't come to us. However, this history was told by the parents to us.
Okay. Okay, let's just go back. Now with this presentation that you have in front of you, that is the child, let me summarize, the child has hepatomegaly. He has had a convulsion with those, episodes of hypoglycemia-like picture, and he's had 2 generalized tonic-clonic convulsions also, with nothing else, no jaundice, no rickets, nothing else. Now, what is there that you will be the first possibility in your mind? We'll go to you first and then the panelist.
Could you specify what kind of IV infusion was given?
We have no details about it.
I see, just IV infusion.
Just an IV infusion.
Non-ketotic hypoglycemia can be one of the differentials.
Non-ketotic. Wouldn't we go by things which are much more common around us, much more common that we see here?
But that could be one of the things. Maybe because milestones are not normal, the child...
Just...
The milestones are all normal, the child is all grown well, there's been no previous history. It could be just one of the differentials.
Okay, one.
The early morning hypoglycemia pointing more towards.
Okay, one. And is there anything else? Hepatomegaly with hypoglycemic-like picture with convulsions. type 1. Do you want to really classify glycogens? Just tell me glycogen storage disorder. That's it. I'll be happy with that.
Could we go back? What was the physical exam on the baby?
Yeah.
Was there any information on that?
She's given the system exam.
Oh, she did. Oh, I didn't. I missed it.
Hepatomegaly.
Oh, yeah, that's right.
Oh, you hadn't shown the system exam? You had shown.
Oh, she has shown it.
She had shown.
So there is hepatic.
Can we take the question now back? Is
Yeah.
there anybody else who want to say something? Okay, so we'll take the question back to to Dr. Priya, and would you tell us as to what would be your differential diagnosis in this child?
So here we've got a child, a full-term child with a history of increasing abdominal girth, a history suggestive of hypoglycemia, confirmed on physical exam that now there's no icterus, there's no rickets, there's isolated hepatomegaly, and it's quite massive, right? You said the span
11
was 11
centimeters.
centimeters. With
For a
no
5-year-old.
splenomegaly, no signs of liver dysfunction at this point, and now has gone in with a history of convulsions, and which was recovered with IV fluids, which most likely I would say had some amount of glucose in it. I think typically that's what an IV fluid would be. So now given that, what would you think about in this scenario? I think someone did point out in the audience.
Yeah. Okay.
What did you say?
Okay. Okay. So
So
somebody said GSD there. Somebody
Right.
said glycogen storage disorder. So we'll.
right. So I think that is a very common.
There's one more thing that I think we need to remember
Yes.
is that this child had one convulsion about at the age
the
of 1.5 years.
yes.
Since then to 5 years, he's had no further convulsions.
But there's also a history of wanting frequent feeds.
Yeah.
And the only unusual part in this history is that the height of the child is still, he's not.
no failure to
there's
thrive and
failure to
no
thrive.
stunting.
So that could be explained because of the frequent feeds, but it would be nice to get that nutritional component also. What is the child really eating? So at this point, do you have any of that information?
The child was on a normal regular diet. There is nothing special feed given to the child every 2 hourly as demanded by the usual diet
Okay.
which the parents were giving to the child.
So that's a good explanation why this child is not failing to thrive. The weight also could be related to the massive hepatomegaly that the child has. So here one of the clues is that the weight may actually be pretty good, but the height shows some stunting if this had continued for some more period of time of persistent hypoglycemia. So now looking at this, do we ask about any further labs or?
We'll ask after this if you can just commit glycogen storage.
Right. So I would say that this could be very common glycogen storage disease, either type 1 or type 3. Or it could be type 11 in the early stages where you've still not shown frank features of rickets. Or it actually also could be type 6 or type 9 glycogen storage disease. So these would be the ones.
So she's said 1, 3, 6, 9 and 11. We'll go ahead and look at the, okay, somebody wants to.
Glycogen storage disorder, no doubt, is the first differential. Can I ask,
Yes.
with the onset at 1.5 years of age, with there's no history before that, and a well-thriving child, no weight and height are normal for his age, with hypoglycemia, with hepatomegaly, can it be hereditary fructose intolerance? Differential, just a differential second. Which is GSD is first.
You're absolutely correct. It could be, and the third one actually, which we
Can
should
it
be thinking of.
Other forms of alternate, but still age is a bit.
No, just ask first question. Let us have the first question cleared first. You said hereditary fructose intolerance, yeah.
And it could be. It absolutely could be because here.
So
we're saying
we'll
the
stop
child
at that. She said yes. We'll go ahead with the investigations and then maybe is there any other differential
Right.
diagnosis you have in mind?
Alternate galactosemia like
Okay.
galactokinase or epimethylation.
Okay.
Right.
Just we'll go ahead with the rest of the.
Right.
Okay.
And then I think you needed to, in your history, you said that it requires frequent feed. So that starts to take away fat acid oxidation right away because fat acid oxidation, the fasting hypoglycemia, it's after like an overnight
feed.
fast. So it's already going towards something. If you think about the sources of glucose, the first source is glycogen, the second is from neoglucogenesis, and the third is from fats. So given your history that it's very early, it's telling us that it's a defect likely in glycogenolysis. That's why it's coming on so early. So that's what I could gather from your history.
Okay. Can we go ahead now?
Our initial impression was a 1-year-old
Just-
male child with hepatomegaly with seizures. So differentials, we thought of a metabolic liver disease, and because of the consanguinity and the early age of presentation, and what we thought, these were the differentials we thought at the initial stages, one being the glycogen storage disorder, a fatty acid oxidation defect, a milder variant of congenital disorder of glycosylation, cholesterol ester storage disorder with seizure disorder.
Okay, we won't discuss the last two. We'll just
Yeah.
stick to the first one, and we'll go ahead with the first one. What did you do after this?
We investigated this child further with a liver function test showing the SGPT and OT on the higher range, with a GGT also being raised and a normal coagulation profile, the lipid profile being normal. However, there was one documented hypoglycemia in the meantime with a normal uric acid level.
So one of the important things is if you're really considering a GST, in this panel of yours, you should have also done a lactate.
We have
Yeah.
the further
Okay,
investigations.
so it's not.
Show us the lactate.
The complete hemogram was normal. The lactate levels were also in the normal range. We initially thought of a viral cause, so even we did viral markers, which came out to be negative. USG abdomen showed hepatomegaly with no other abnormality, with a normal ecotexture of the liver. Urine reducing substances were negative. The CPK levels were normal. Plasma and urine amino acid gram were negative. Calcium profile being normal.
Okay.
So why did you do the, when you just go back to your previous slide? So here you've already made a diagnosis, pretty much looking at this, if you've narrowed it to a glycogen storage disease, you've got an increase in your liver enzymes, which are markedly elevated, and also an increase in your GGT. So how would you now separate it amongst the glycogen storage diseases? Which direction would you go? Which GST does it seem likely to be?
Very mild.
Did you say type 1? Oh, why would you say type 1? So,
But see, the documented hypoglycemia is very, very not so marked.
I think
We do not have. No, this 50 came from some
that
other
was the
hospital. So they don't have information about that.
so.
Yes.
Right, so here's the first, forget the CPK, we've not yet obtained a CPK. If you look here at an AST and an ALT in these numbers, it very, very rarely, this was not typical of GST type 1. So think about it that when you're storing glycogen, if it is normal glycogen, just qualitatively normal but quantitatively increased, your AST and your ALT will be normal. When you're storing glycogen that's abnormal, then you start getting an increase in your AST and your ALT. So the first thing that you can start excluding just looking at this is GST type 1. You may see a mild elevation in the early stages, but you'll never see it in the thousands
Right.
like this. So now we are thinking about which other GSTs, type 3, type 6, type 9. Type 4
Usually
could
don't.
present with these kinds of numbers, but
By now they would have.
yeah, I mean, but you do
Splenomegaly
have a milder variant of type 4 that could, so we cannot completely exclude it at this point. I mean, given these high numbers, the thing that I would safely exclude at this point is GST type 1.
I think also the fact that the triglycerides, cholesterol, uric acid are normal.
Normal.
One would not really
Lactate.
strongly consider, and
Lactate.
lactate
No
also,
rickets.
GST1.
Right, right.
Okay. So
Our final impression was a progressive hepatomegaly without a splenomegaly with seizures, one documented hypoglycemic episode, and raised liver enzymes with normal synthetic and coagulation liver function. So it further led us
with
to
no rickets, with no
no rickets.
stunting, with normal lactate and normal triglycerides, almost normal.
Right. So one of you actually mentioned that the CPK was normal, and so
Yeah.
you would exclude, what did you say? So that's the first wrong thing. There are two forms of GST type 3. Type 3A, which involves both the liver as well as
Muscle.
the muscle. And then there's 3B, which is about only 15% of all the GST type 3s, which is just liver involvement. But the other key lesson to remember is that a normal CPK does not exclude GST 3A. You can have a normal CPK and still have GST type 3A. So I would not exclude it just based on that. I would also suggest, let's go back and look at one more thing here. Yeah, so here when you're looking at it, you've got an increase in AST, ALT as well as GGT with a normal, normal cholesterol and triglyceride. So in this scenario, the likelihood is it could be 3, it could be one of the severe forms of type 9. Which one would you say in amongst the type 9? So there is the alpha variant, there's the beta variant, and there's the gamma variant. And I think the literature really talks about the gamma variant being the more severe form, which could go on to progressive liver failure. But I think that's a representation of the literature. Some of the even, is this a male child? What did you say?
Male.
A male
It's
child.
X-linked in.
So it could be an X-linked, even the alpha, and they also could have an increase in these liver enzymes. So we should not exclude type 9 based on this.
Okay.
So this led further to go ahead with the liver
What is the
biopsy.
next so what is the next obvious investigation you want here? Okay, so let's just have the
No,
liver.
actually, let's go back again to basics. We talked about hypoglycemia. Have we figured out if this is a ketotic or a non-ketotic hypoglycemia? I think one of you was asking that question, and why is that important again? Correct. But even amongst the GSTs, there is a separation of the ketotic versus the hypoketotic hypoglycemias. So I think it's very important. Do you know what they were, the urine ketone?
The urine ketone bodies were traces. That's what the report we got was traces. Traces.
So Mamta, do you want to?
Okay, so we'd like to ask the audience then, which are the glycogen storage diseases where you get a very hypoketosis, and where the ketone response is quite high? Which is hypoketotic and which No, that's one is hypoketotic, and in 3 you'll get very high ketone body production.
Okay.
Also 6 and 9, they are very markedly ketotic, and I think we tend to forget about that. Yeah.
My question is, can we really talk about that based on the urinary ketones, because we're not doing ketones here in the blood?
So I think that's another important point to really think about, that sometimes you can miss ketosis if you're just looking for urine ketones.
Yeah.
Your plasma ketones tend to rise earlier than your urine ketones. And we actually use now a ketone meter, to check, because sometimes you can have a normal glucose, but in a stress situation, your ketones are up because you're trying to utilize energy in another form. So looking at the plasma ketones gives a lot of information in terms of the stress level, and you can prevent hypoglycemia or miss impending hypoglycemia because your glucose is normal, but you're in a state of ketosis.
Okay. So we go on to the liver biopsy.
The liver biopsy showed a preserved lobular architecture and cord pattern. The hepatocytes were swollen with pale cytoplasm and eccentric lobulated nuclei with intracytoplasmic glycogen being present.
Is that the only information? Are you going to give us some more?
No, that's all that they have on the...
we have got.
Okay.
What else do we want to know?
We would also like to know whether there's
Fibrosis.
hyperglycogenation of the nucleus, presence of fibrosis, and the PAS stain. So these are 3 things which, if you are suspecting a glycogen storage disease, the liver biopsy would have.
Dr. Mamta, it would be better if you tell the audience as to why do you want to know this?
Okay.
We're running out of time.
If we are looking at a differential of type 1 and type 3, which are the common disorders in this kind of scenario, in type 1, the biopsy would show liver cell nucleus, which has glycogen inclusions. Whereas in type 3, you will have fibrosis, and sometimes in late stages even cirrhosis. And the PAS stain would tell you that the storage material is glycogen, and what you would need to do is a PAS with a diastase sensitivity.
Possibly
So,
they mean that they have done that and the glycogen is present. That's how they possibly labeled it as glycogen. So fibrosis is another thing we needed to know. Okay.
Just one more thing on the biopsy. It's important to collect the sample in absolute alcohol. Otherwise, you'll not be able to get it if you do it in a regular formalin.
Okay. So this is all we know about the biopsy. Next slide. So what type of, I throw this question to the panelists, starting from Dr. Priya and then.
So in this situation, I don't know if you've got sufficient information. The one thing I can say, it's not type 1.
Yeah.
It likely is a type 3, and it very well could be a type 3A. It also could be a type 9, given the information that we have, except that on the biopsy, what I could see is there's no evidence of periportal fibrosis. So that's the only confounder that I can see, but that's what I would say that this is. In terms
Either type 6,
no,
type 9, or it's type 3.
Yeah.
But fibrosis is obviously not shown there, and they've not
Correct,
mentioned.
yeah.
So you would go with 9.
I would go with 3 actually.
You would
because
go with 3.
Common things being common, I think that type 3 we
It's
see
much
a
more
lot of
common,
it.
that
Yeah,
I agree.
yeah.
Even in India, we're
Yeah,
finding.
yeah.
Okay. The next.
Now the child is being managed with a special dietary advice with routine monitoring of liver function test, lipid profile, the blood sugar level, and serial USG abdomen monitoring.
Okay. So now I would want to know from Dr. Priya as to keeping the type 3, what is the dietary advice that you would?
So I think the first critical thing to remember is that there's no need for a restricted diet like you have in GST type 1. You don't have to do the lactose or the fructose restriction in GST type 3. The second thing is that you want to use protein as an alternative source of energy. You don't just want to use cornstarch, which is the standard as a slow release for glucose, but too much cornstarch actually is problematic in type 3 because you're only going to be building up more and more abnormal glycogen. So I think adding a high protein diet, so in the order of about 2.5 to 3 grams per kilogram, is really critical, especially in a type 3A, because it's an alternative source of energy and you can have it through neoglucogenesis. The third new concept that we're learning about is the use of medium chain triglycerides in type 3 as another energy source, because then you can release not only the glycerol, but you have the acetyl-CoA that's released from the MCT, so you can fill that through the Krebs cycle. So that's another important area to think about.
Okay. Is there anything else, during this diet, what do you really see? I mean, in glycogen storage 1 or in 3, what are the problems that you face with these children?
So that's another thing for type 1. Because of the restricted nature of the diet, you have to be concerned about vitamin D deficiency and other nutritional deficiencies. We focus so much on cornstarch that we forget about the child as a whole in terms of nutrition. And especially we see a lot of vitamin D and a lot of low calcium issues in GST type 1. If GST 3 is managed correctly, you should not see this. But I think today we see vitamin D as a major issue that's going on. And then for the muscle disease, in terms of management, you do need good physical therapy, but also a good exercise regimen to manage these patients.
Okay, so the key message would be okay. Yeah.
Sorry, I just want to make one comment. Given that this is a general paediatric meeting and we have ridiculously high-end expertise on metabolic disease, for the general paediatricians, they see a child with a big liver, hypoglycemia and seizures.
Yeah.
So they presume that it's glycogen storage disease. In 1 or 2 lines maximum, I wonder if Dr. Priya could give her a summary of why the hell we care which type of glycogen storage disease it is, in terms of, I mean, what the paediatrician wants to know is outcome, risk of death, complexity of management. I mean, that's the only reason to differentiate
right. So I think that GST type 1 really is lethal if you don't treat it, because you've got a block because of the enzyme deficiency of glucose 6-phosphatase. It's a block in both glycogenolysis as well as neoglucogenesis. So if you do not provide a constant source of free glucose, either through the protected, through cornstarch, you can actually lose a baby. GST type 3, depending on the nature of the mutations, they do have some reserves because they have intact neoglucogenesis. Yes, glycogenolysis is partially blocked. They can still break it down with phosphorylase. So I think that's why it's really critical. And in terms of prognosis, I mean, they're all living into adulthood. But the GSTs in general, I would say metabolic disease in general, I think we have to keep at the back of our minds the development of hepatocellular carcinoma. In GST type 1, it's an adenoma to carcinoma transformation. In GST type 3, it's a cirrhosis carcinoma transformation. But we have to keep that in mind. So metabolic control is very, very adequate in these diseases.
Could I just make one more comment? Girish, if you can hold on. If you see, this diagnosis was delayed for 5 years just because when the child got a seizure at 1.5 years old, nobody checked the blood glucose level. So I think for the pediatricians here, if a child comes with a seizure, please check the blood glucose. Very often it is a hypoglycemia which is missed out.
Yeah. Thank you very much.
Thank you, ma'am.